now go to the exciting part of, so we heard earlier about patient clinical literacy being a challenge or something to aspire to improve, no, for our participants. So the question is, why is patient clinical literacy important? And how can we improve it? And how does it relate to our stigma and discrimination network? To tell us more about it, ladies and gentlemen, Dr. Todd Pollack. Todd, over to you.
Thank you, Kate, so much. And good, I guess, morning to everyone, evening here. I'm very happy to be invited back to speak to the network. Let me just share my slides. All right, are we seeing the slides and hearing me well?
Yes.
Great. So yes, first of all, congratulations to everyone for some really great achievements, progress so far in your S&D QI network. I was very interested to hear a lot of the treatment literacy indicators and quality improvement work that's ongoing. And I think it makes my talk hopefully quite relevant. I learned a lot from hearing the last two presentations, and I noticed some similarities to what I'm going to talk about in terms of quality improvement projects for literacy, and hopefully some things that I can share as well that you can learn from. So I think, first of all, I think we can all agree that health or treatment literacy is a very important component of person-centered care. But, we're doing a quality improvement stigma and discrimination network. So, why do we focus on treatment literacy in this network? And hopefully I'll show you some information to help you understand that. But generally that we know from a lot of studies over many years that patients with better health literacy are more able to engage in their own care, are less likely to report stigma, and I think most importantly are empowered to advocate for themselves for better care. So I do think it's an important topic to address in this network. So here's the outline for my talk. When I was putting this together, I realized that I think it's kind of important to go over some definitions. So I'm going to start with that and then just give you some very sort of an overview of the data around literacy and HIV outcomes. Talk a little bit about, I think, an important gap in literacy as it pertains to the understanding of undetectable equals untransmittable. And then I will share some experience from my team's work in Vietnam on using quality improvement for improving treatment literacy, similar to some of the ideas just presented in the last two presentations. So let's start with some definitions. So first of all, what do we mean when we talk about the concept of health literacy? So health literacy here is kind of talking about health in general. So we're not specifically talking about the HIV field. And one definition is that it's the ability to access and use health-related information to help one inform and improve their health decision-making, their behaviors, and ultimately their health outcomes. So it's a very broad definition that incorporates a range of different activities that are important for individuals when engaging with the healthcare system, such as being able to read and analyze their own information, being able to navigate through a healthcare system, being able to engage in self-care and chronic disease management, understanding concepts such as risk, probability, in order to weigh risk and benefits when making decisions and ultimately taking action in terms of treatments for a disease condition or prevention to stay healthy. So that's health literacy. But we also hear about treatment literacy. And I think that here it's important to understand that treatment literacy includes a big emphasis on the element of empowerment. And treatment literacy is something that really came out of the HIV movement in the United States in the 1990s, where community activists recognized that in order to fight for access to treatment and for human rights, people needed to understand the science of HIV. And I think nowadays, the Treatment Action Campaign, or TAC in South Africa, are really kind of the leaders and champions in this idea of empowerment and treatment literacy. And because they adapted this idea, arguing that using a, quote, right to health approach is important. And I left a quote here from someone from Treatment Action Campaign that I think kind of illustrates what I mean by treatment literacy in this context, that it includes an empowerment element, arguing that armed with proper knowledge, people living with HIV can become their own advocates and, quote, demand their rights when proper care is not available to them. And the TAC group came up with this treatment literacy model that basically outlines a roadmap for individuals as they become more HIV literate and as they begin to advocate for themselves and advocate for HIV literacy in general. And the model includes 3 different zones: the capacitate zone, the empower zone, and the champion zone, as you can see in the diagram. And it uses a series of I statements to summarize how individuals can first capacitate themselves to understand HIV better, increase their own self-efficacy, and challenge their biases. So you can see some examples of the I statements is: I avoid dealing with or talking about HIV issues. This is in the capacitate zone. Or I do not seek HIV prevention or treatment services and do not know how to access them. So once an individual kind of can overcome those statements, they might enter into the empower zone, where they begin to speak out to educate others and encourage positive behavior change among their peers. So some examples in the empower zone are: I understand and talk about HIV issues, or I actively update my knowledge and accurate information on HIV issues. And I know when and how to seek HIV prevention and treatment services. And then finally, in this model is the champion stage that emphasizes the importance of championing continued effort and engagement in HIV literacy and maybe more importantly, in addressing the structural and systemic barriers to care. So this is the model from South Africa that I thought was interesting to share with you. And also, when I was researching for this talk, I came across this paper where they coined another phrase called prevention literacy. And this is, I thought quite interesting, as we have sort of a explosion of new HIV prevention technologies with PrEP and injectable PrEP. And so HIV prevention is becoming much more complicated, on par now with HIV treatment. And so these authors advocate that we also need a terminology of HIV prevention literacy that parallels the idea of treatment literacy, with its emphasis not only on understanding the relative complex technical information about a range of HIV prevention methods, but again, also on the question of access to these new prevention methods as a fundamental human right. So again, sort of the empowerment idea in the literacy concept. So that's some definitions. Now, as I talk, the rest of the talk, I'll kind of use literacy and health literacy and treatment literacy a little bit interchangeably. But hopefully from the definitions, you can sort of see some of the difference. And in the HIV field, we tend to use treatment literacy because of that empowerment concept. So just to summarize very briefly, given the amount of time we have, about the impact, the relationship between treatment literacy and HIV outcomes, I think it's quite clear to say that literacy is an important determinant of someone's health. And in the HIV field, we have studies that show that better HIV knowledge is associated with better HIV outcomes, such as greater odds of achieving HIV viral suppression, better rates of retention and care, and may be very important to this network that people living with HIV who have inadequate health literacy are, in some studies, more likely to report negative healthcare perceptions and experiences, and also to be less confident in their ability to self-manage their disease compared to those who have adequate health literacy. Thanks to Bruce for calling my attention to this recently published paper that is a systematic review and meta-analysis of HIV-related stigma and its associated factors. So it reviewed the literature of all different factors that might be associated with HIV-related stigma. And here I just showed the meta-analysis figure that's related to literacy and stigma. But in general, the paper found that a number of factors were associated with a lower likelihood of having HIV-related stigma. So some of those factors included being of older age, having better social support, having better education, or higher socioeconomic status. And then there were factors that were associated with having a higher risk of HIV-related stigma, such as mental health or non-disclosure of HIV status. I think these factors we're probably quite familiar with in this network that focuses on HIV stigma. But one of the other factors that was strongly associated with stigma was HIV literacy. So as you can see in the number of studies and then summarized at the bottom in the green diamond, there was a strong association that said that those who had better knowledge about HIV or better HIV literacy had a lower risk of reporting HIV-related stigma. Now, a lot of you are mentioning, I think, are involved in PEPFAR-supported programs. So I thought it was good to mention just one slide about what PEPFAR thinks about the idea of treatment literacy. And so I looked up the country and regional operating plan from last year, the guidance that PEPFAR sends to all countries. And they have a group of core standards. There's around 20 core standards that all PEPFAR programs need to include in their programming. And one of those core standards includes treatment literacy. They really emphasize treatment and another terminology here, viral load literacy. And they say in the guidance that all HIV programs should offer activities that help people understand the facts about HIV treatment, about HIV infection, HIV treatment, and viral load. And here they also mentioned the undetectable equals untransmittable message, stating that this messaging and other messaging that reduces stigma and encourages engagement and care should reach the general population and healthcare providers. We're not going to talk. I'm not going to talk about undetectable and untransmittable in general, because I think we all understand that's a very sort of powerful and important message when we're talking about reducing HIV-related stigma. But I did want to share some data about sort of how good a job we're doing at spreading that message of you equal you to those who need to hear it. So this is a study from 2021 that was conducted in more than 2,000 people living with HIV around the world. It was a survey. And in one of the questions, they asked the participants whether they had been told by their health care provider about the U equal U message. And overall, about 70% of 60 to 70% of the people living with HIV surveyed said yes, they had been told by their health care provider about U equal U. But as you can see in the Asia region, that was the lowest of all the surveyed regions, where only about 50% or half of PLHIV reported being told by their health care provider about U equal U. And as you can see at the bottom of the slide, the countries involved here did not include the Philippines. The Asian countries were Russia, Japan, Taiwan, South Korea, and China. But nonetheless, I think it does show there's a lot more work that needs to be done to make sure that all people living with HIV are educated about U equal U in terms of HIV prevention, but also because of its impact on HIV-related stigma. And it's not just those living with HIV, but those who may be at risk of HIV or who are part of key populations that need to know about U equal U. And again, here's a study that was presented at the International AIDS Conference a couple of years ago that looked at more than 15,000 gay and bisexual men in the Asia Pacific region and asked them whether they were aware of the U equal U message. And once again, and this was a group, again, this was a group of people who were living with HIV, who were HIV negative, and who were not at this time not aware of the HIV status. And overall, we can see actually in this study that those living with HIV, 76% of those surveyed said they were aware. But if we look at the HIV negative group or the HIV unknown status group, much less had heard about U equal U. So again, showing that in terms of literacy around this message, there's still a lot of work to be done. Okay, so that's all sort of for the background. Now I want to share a little bit of the experience that we did in Vietnam in terms of using quality improvement to improve treatment literacy. So when we started our S&D QI network a few years back, similar to the survey data that you guys presented earlier in this meeting, we found that some of the biggest gaps actually was around the treatment literacy. So this is some data from 3 provinces with more than 800 people living with HIV who were on ART that were surveyed and asked whether they knew what their latest HIV viral load result was. And you can see overall only about half of those surveyed said that yes, they knew what their HIV viral load was. And when we thought about that, when we thought about what that meant, not just for sort of understanding one's treatment and whether or not one was being successful with that treatment or not, but when we thought about that in the context of U equal U again, and the importance, meaning, especially for HIV stigma that message can impart, we realized that even though Vietnam had very high national viral load suppression rates, and therefore people with HIV in Vietnam were really poised to benefit a lot from the idea of U equal U, if so few people even knew that they had an undetectable viral load, then they certainly couldn't benefit from that. So we looked at the data a little bit closer because we asked people if they knew what their HIV viral load was. And if they said yes, we asked them if they knew what the value was, or at least if they knew if it was less than the 200 mark, which at the time was what the studies were saying sort of met the criteria for U equals U. And we found overall that only 35% of those surveyed sort of knew that their viral load was undetectable, even though we knew from program data that almost everyone had an undetectable, or at least at that time, less than 1,000 copies according to the program data. So just like the previous presenters, we went forward with a QI approach to think about improving viral load literacy. In this case, trying to help patients to know. The goal was to increase the percentage of patients who knew the result of their most recent HIV viral load test. So here's a simple fishbone diagram that one of the clinics put together as part of their QI process, identifying different barriers or reasons from the three categories of health staff, patient, and clinic or systems issues. And from the health staff, some of the issues that were recognized was that there was a lack of time for providing counseling. These are in public HIV, busy public HIV clinics. That the healthcare workers didn't recognize this as important. In fact, the healthcare workers were providing their viral load results back to the patients by just saying, basically, you're good, not really explaining what undetectable meant, just like you're good, keep going on the treatment, you're doing well, but not providing the actual result or telling them undetectable, explaining what that meant for their health or for their partners. And then from the patient side of things, they didn't feel empowered to ask the health staff to explain more or to get more information. I think that was kind of one of the most important things here. And they also lacked understanding of the importance of knowing that their viral load is undetectable. And from the clinic point of view, similar to, I think, some of the previous presentations, there was a lack of information, IEC materials about ART and viral load results, and lack of sort of standard procedures for providing the result of testing back to the patients. So the clinics underwent a quality improvement project with a series of PDSA cycles, which are summarized in this slide here, going from that 30% of people who didn't know what their viral load was, with the goal of getting that down to less than 10% who didn't know their viral load result. So in the bottom box, you see that the first set of QI activities was providing training to the healthcare workers about U equal U and the relationship with viral load testing, and developing a patient information leaflet about the HIV viral load test, and making sure that education on viral load is integrated into the counseling. And that had some effect. And then, the QI team kind of went around for PDSA cycle 2, and felt that what was important in the counseling was not just to provide the result of the viral load, but to focus on what are the benefits of an undetectable viral load, again, in terms of someone's personal health, but also in terms of the HIV prevention method, the HIV prevention message as well. And then improved on the next round up to 80%. So then there was a third cycle where, because the HIV viral load test is only done once a year, many of the patients were not, when they came back for their ART refill, there was still no counseling happening about viral load testing. So in the PDSA 3, during each visit, even if there was no viral load test that visit, the clinic was reminding the patient what their latest viral load was and what that meant, and when their next viral load test was scheduled for. And then in the final PDSA cycle, there was a check of patient understanding, where sort of a teach back approach, where the healthcare worker would ask the client to repeat what they understood about their viral load and the meaning of that. And finally, that helped reach the goal. So I just mentioned the teach back method, so I put one slide about that. This is sort of a very kind of classic method to help improve health literacy in general. The idea that when you have a new concept that you want to explain to a patient, There's first step is that the clinician uses plain language to teach the key points about the concept, and then you ask the patient to recall or explain you basically ask the patient to repeat back to you what they understood. You might say something like, I want to be sure I explained everything clearly. Can you please explain it back to me so I can be sure you did? And then that helps you assess the patient's understanding. So this is kind of what we did in the fourth PDSA cycle during the project to check patients' understanding of their viral load result and its meaning. And then I really wanted to return to this idea about empowerment through treatment literacy. So in this slide, I share sort of another quality improvement approach, which we implemented, which is the community scorecard. And in this approach, we have a set of clients from a clinic who score the quality of services that they're receiving. It's kind of a subjective scoring on a scale from 1 to 10 based on a series of different indicators. And then the healthcare workers also score separately how they think the quality they're providing is on those indicators. And then the two sides meet together as depicted in the picture in the bottom of the slide and discuss, share their results of how they scored each of the different quality indicators. And if there's a discrepancy in terms of the scoring, they discuss it out and try to come to common ground and common understanding as to maybe why the clients think, gave a lower score compared to the healthcare workers, or often vice versa. And one of the things that I found interesting in this method, because often the patients do not feel very empowered or very confident to speak up and talk about what they think is not going well at the clinic, and they often score things very high. They do not find many gaps when doing their scoring, and often we found the healthcare workers, gave a lower score for many of the indicators compared to what the patients scored as. But after we had gone through a lot of training on the importance of knowing your viral load test and its relationship to understanding if you could reach the U equal U and what that meant, we found that the patient side was consistently scoring the quality of counseling on viral load and counseling about the U equal U message very low. So you can see here, like in this one example that I showed here in one clinic, they scored it a 5 out of 10, which is one of the lowest of the different indicators that were scored. And I was reflecting on that, thinking that it wasn't that the healthcare workers were necessarily doing a much worse job at that particular aspect of care compared to other aspects. It was just that the patient side, through the education they'd received and opportunities to discuss amongst themselves, had become empowered to sort of demand better quality of care, better counseling when in this community scorecard meeting with their healthcare worker, with the healthcare workers caring for them. So hopefully I'm explaining that well, but that for me, that was like a good example of how literacy had empowered the clients to demand better care. And since I've been talking a lot about U equal U, I wanted to end with this new latest initiative that we're doing in Vietnam to encourage counseling and education, improve literacy around U equal U from healthcare workers to clients. And we're calling it the 3 Moments Health Worker Educational Campaign. And the idea here is that there are 3 key moments when undetectable equals untransmittable should be, that counseling on U equal U should be provided to patients. And the first moment is at the time of outreach or HIV testing, like peer outreach or HIV testing, either community or facility-based. And the second moment is at the time that patients who have been diagnosed with HIV are starting on ART. They should be educated about U at that time. And then the third moment is at the time they get their viral load tested result, hopefully when they've achieved undetectable viral load and can celebrate having reached U. So we sort of put it into this into this sort of mnemonic of the 3 moments for counseling, trying to play off of the 5 moments of hand hygiene, that the 5 moments you're supposed to wash your hands that healthcare workers sort of know about in their training. So now we're trying to remind healthcare workers of these 3 key moments that they should be educating their patients about U. So that's what I have. So in terms of my summary for what I tried to share with you today, I think the first point is that treatment literacy is not just about understanding the names of your HIV medicines or your viral load result, but it's about empowerment, that people feel confident to manage their own care, but also to demand higher quality of care from the health system, and to demand, care without stigma and discrimination. There's plenty of data that shows that HIV literacy is associated with lower stigma, that better HIV literacy associated with lower stigma and improved HIV outcomes. I think that literacy around viral load testing and U are prime areas for improvement because of that important anti-stigma message or anti-stigma impact that U has. And community engaged quality improvement approaches are effective at improving healthcare worker counseling and improving client treatment literacy. And hopefully I showed some examples of that today. So thank you very much. Try to keep it short at this late hour. Thanks to my partners and happy to take any questions.